I guess we will start. So welcome to the event titled "The Team Takes Command in MDS, Guidance on Diagnostic and Treatment Principles for Risk-Based Care and Beyond." My name is Guillermo Garcia-Manero from the Department of Leukemia at the University of Texas MD Anderson Cancer Center. And I'm really honored and happy to be today with Dr. Rami Komrokhi, who is the Vice Chair of the Malignant Hematology Program at the Moffitt Cancer Center in Tampa, one of the leading institutions in the care research in myelodysplastic syndrome, and also with Dr. Aditi Sastry, who is the MDS lead at Albert Einstein Hospital University in New York City. And with that, let's start with the program that I think actually is extremely interesting program and very with excellent timing. As a task meeting, we had two very important presentations that I think are going to move the field and the care of our patients with MDS quite significantly. So this is kind of a copy of the famous AML chronology of therapeutics slide, although a little bit more modest. But it's actually very important for us as MDS researchers to really think about actually significant progress that we, I think, are achieving. So basically in the 70s, people start talking about the cytogenetics. Then in the late 90s, Dr. Greenberg and big international team put together this IPSS classification. That, of course, is not therapy, but it was really an important step forward because it served as the framework to think about this disease for a long time. And then in 2004, we saw the first approval of a hypomethylating agent, azacitidine, that became the standard of care around the world for patients with MDS, particularly those with high-risk disease. And then thanks to work performed at Dr. Komrokhi Institution by Dr. List, lenalidomide was approved in 2005 for this very specific subset of patients with del(5q) minus disease. A couple of years later, we got the decitabine approved, led by Dr. Kantarian here at MD Anderson. And then we had a hard time getting more drugs for our patients, but there was a lot of work in many centers, including Albert Einstein, trying to understand this disease at different levels. So we came up with the IPSSR classification around 10 plus years ago. We started applying next generation sequencing techniques for our patients. And then finally, in 2020, we saw two drugs approved for our patients. The first one was luspatercept. We're going to talk about more about this agent in the next few slides. It was first approved as second-line drug for patients with ring sideroblastic anemia that were transfusion dependent and they were not benefiting or they were not a candidate for an ESA. And then a few months later, we also led the approval of cedazuridine and decitabine, an oral hypomethylating agent for patients with myelodysplastic syndrome. A little bit after that, we saw major progress by the development of the IPSSM classification, basically incorporating the IPSSR with the molecular data. And I think at ASCO on Friday, we saw the two presentations from the COMMANDS trial, from the IMerge trial. This is going to be discussed in the next few minutes. But as we were preparing this talk and we were, rehearsing a few minutes ago, we're very excited about the future, hopefully this year, with maybe incorporation of BCL2, maybe anti-CD47 antibodies, and other combinations for patients also with high-risk disease. So I think that all of a sudden we're starting to gain traction. And to me, it's actually very interesting that, to my surprise, it's happening first in low-risk disease as opposed to high-risk disease, where, all of us have been working so hard. But, this is really positive news. Now, despite all this great news and kind of academic advances, there is a lot of work that we need to do. So there is data actually from the Connect Myeloid Disease Registry. This is an important academic group sponsored by BMS, where we see actually that a lot of our patients still receive only supportive care, so no therapy. And we see that actually in our academic referral patterns, where some of these patients, could have received therapy or some type of intervention earlier. And then even the SEER data actually basically suggests that actually the outcomes that we see in our patients are not in the community in general don't really reflect what we publish in our papers from clinical trials, etc. So we have quite a bit of work to do. So the goals of the seminar today are summarized here. So we like to improve your or our understanding of baseline factors that can alter prognosis and help you individualize therapy for patients with MDS. Enhance your understanding also of evidence supporting newer treatments for patients with low-risk disease and high-risk disease, and then prepare you to develop modern, up-to-date management strategies for our patients, both with high and low risk disease. So hopefully in the next hour, we will be able to accomplish a little bit of this. So let's start with some new developments in terms of baseline assessments and prognostication. So I think this is very well understood by the community now. There's some diagnostic criteria and differential diagnosis of this disease. Of course, you need to have some degree of cytopenia. You need to have a bone marrow aspiration and or biopsy to have really criteria. That basically means that you have evidence of dysplasia in the bone marrow. You have probably excess blast in a majority of the patients, at least over 5%, and then maybe some clonal abnormality that could be cytogenetic or molecular. You also need to exclude other situations that could mimic myelodysplastic syndrome. I actually, in my practice, very rarely nowadays see B12 or folate deficiency, but I have to say a couple of times a year, I see a patient with a newly diagnosed of HIV disease. That was actually surprising to me, but something that you have to pay attention. The rare patient with copper deficiency, patients that are not very open to you in terms of alcohol abuse, medications. But actually, I think where we are starting to get very interested, and it's actually complex, is the bottom things, things that may overlap with myelodysplastic syndrome, inflammatory autoimmune conditions. Dr. Komrocki always teaches me how, for instance, ITP can be a prodrome actually sometimes for myelodysplastic syndrome. Some of this overlaps with other autoinflammatory conditions. Now there is a lot of interest in condition on Bexas syndrome as a kind of an entity that puts together kind of bone marrow failure with severe inflammatory conditions. And then, of course, more complex congenital disorders or other situations like aplastic anemia, LGL. I actually see patients that are referred. This also happens a couple of times a year with hairy cell leukemia that actually are referred to me with myelodysplastic syndrome. So the bottom line is that a bone marrow aspiration biopsy is fundamental actually for this differential diagnosis. Together with the progress that we have seen in terms of drug development, there's also quite a bit of movement in terms of classification efforts. For many years, we used the WHO classification. And by the way, to be open, that's what I still endorse. But in the last edition of this, the 5th edition, I believe it's called, of the WHO classification, there are actually significant changes that are important, starting actually with a different name for this disease, not referring to it as myelodysplastic syndromes anymore, but as myelodysplastic neoplasms, in parentheses, MDS. To be open and just to make Rami a little bit happy, or I want to make him smile a little bit. I think actually it's a mistake, because I really think from the conversation a minute ago that MDS actually is a syndrome. But whatever it is, we need to follow the rules of this WHO, and that's how we are now writing our papers. I'm not going to spend a lot of time here because I like to really go through more of the therapy. I think you have access to the slides, but basically realize that we are changing some of the terminologies. We're starting to talk about specific mutational alterations that may define a specific subset of patients, for instance, SF3B1, biallelic P53. Now we talk about MDS with increased blast, that could be B1, EB2, or those patients with fibrosis. And remember that it's up to 20% blast, this MDS subset of patients. So this is a summary of what's really happening. So I already said that we kind of changed the name. We have a specific genetic subtypes, the MDS5Q, SF3B1, biallelic TP53. Some of the alterations that we were seeing before in the kind of context of MDS now are considered acute myelogenous leukemia. For instance, the very rare patient with an MPN1 mutation now will be acute myelogenous leukemia. And also the very rare patient with very poor prognosis with an inversion 3 or a MECOM rearrangement that now will be considered AML. In my opinion, this is semantics, because whether you call this MDS or AML, the therapeutic approach is probably identical, and the prognosis for the MPN1 MECOM very dissimilar, but very specific. There's also this distinct entity. This is actually of interest to all of us here. There's this so-called hypoplastic myelodysplastic syndrome. It's a little bit of controversy how to approach that. We treat this as a plastic anemia, but this may not be universally accepted. And then again, differentiation between low blast and high blast. And then also this issue of this ICC classification, that is kind of like a group that got out of the WHO classification that has a parallel system to call this disease. The other very important thing, and Dr. Komrocki has done really tremendous work here with the IPSSM, is actually the incorporation of these molecular biomarkers in the prognostication of our patients. So we had the IPSS, the IPSSR, We had all this genomic data for like 10 years. And then finally, Dr. Papa Manuel and a very large group of international investigators all over the world actually put together this data in a very large cohort of patients. And then they came with this IPSSM that I'm going to briefly describe in the next couple of minutes. If I take kind of something out of this that I think is very critical, is the understanding that P53 mutations seem to me, and I'm curious to know later what Aditi and Rami think, seems to be increasing. I think we're detecting more. I'm not saying there's more, but as we have these tools, this entity that we used to say is 8% of the patients or something like that, it's actually becoming 30 to 40% of my practice at MD Anderson. So basically, when you apply this IPSSM, you will see the importance in terms of prognosis that having a P53 mutation, but by and large tends to be biallelic in a large fraction of our patients has for our patients. So this is really critical, as you will see in the model. So let's go actually through the tool itself. You can actually access this kind of for free if you go to Google or whatever server you use. I actually, to be clear, I do this with all my new patients actually as an exercise. This will give you both the IPSSR and the IPSSM at the same time. And it allows you to basically think about what is going to be the prognosis of your patients. Many times I tell to BC clinicians that, it's actually not the best idea just to say this is low risk versus high risk. I mean, you do that and then you apply one of these more sophisticated tools and then they tell you, okay, prognosis is like 1.3 years. Yeah, it's low risk, but this is really a bad entity. So I think you will probably start thinking in a more aggressive way how to really approach this. But this is a wonderful tool that you can, I think there's an application actually that you can have on the iPhone. So it will ask you characteristics of the disease, like the percentage of blast, level of hemoglobin, platelet count, the neutrophil count, age of the patient. That's very important. So this is actually age adjusted. And then it will ask you for additional data in terms of what kind of cytogenetics. This is basically the IPSSR kind of vector for cytogenetics. And then it goes through the mutational data. And what you're going to see is that it's going to ask you, do you have a P53 mutation, yes or not? And then it's going to ask you, is this kind of monoallelic or biallelic? So the reality is that I don't think any of us really have the true kind of scientific molecular assay to really say that. So the tool that I applied in my head, if that makes any sense, is that, for instance, biallelic could be someone that has 2 mutations of the P53, very high BAF, or a deletion of chromosome 17 plus, mutation of P53, whereas a single low BAF, probably that would be monoallelic. That's basically how I calculate that in my clinic. This is actually what they will give you this kind of graph. It will tell you this is the very low to the very high risk. And I think that actually is becoming a really important tool that we're all now using in the clinic. Dr. Komrocky at the last ASH meeting actually showed beautiful data confirming some of these results from the original IPSSM groups. So let's start now with the next phase of the talk, where we're going to see how we, as an MDS team, deliver and see if we can integrate this new evidence with multidisciplinary modern care. So let's start with a patient with, or a situation or context of low risk MDS with anemia. And I'm going to ask Aditi and Rami for help here. So you referred gentleman, he's 69-year-old man, seen by primary care doctor. He has kind of modest anemia, I guess, hemoglobin of 9 grams, associated of fatigue, some dyspnea. Primary doctor does all these tests that we also do, B12, folate, etc. We already discussed this. I believe that a bone marrow was performed. I don't tend to do molecular testing in peripheral blood. I mean, occasionally I could do that, but most likely this was performed from the bone marrow. And then this patient has an SF3B1 mutation, has significant percentage of ring sideroblast, and has a low percentage of blast. So now the question to Rami or Aditi is, you need to confirm the diagnosis. When do you refer this patient? And will the IPSSM help you here? Let's maybe ask Rami, as he did a lot of this IPSSM work.
Absolutely. Thank you, Guillermo. So obviously, this patient has significant anemia. It seems he's symptomatic, and the diagnosis is MDS with ring sideroblast in the past. Now this fits the MDS SF3B1. There are some missing information here for us to assume that this is the classical good subtype of SF3B1. So for example, we want to know cytogenetics on this patient, just to confirm that they are not complex karyotype. That will be a surprise. And then the other thing, actually, for the IPSSM, it does predict outcome pretty well. And as you just showed, that the SF3B1 is probably the most favorable. However, even the IPSSM put them in categories based on co-mutations. So if the patients have a mutation, for example, I think the one that most people agree upon is like RUNX1, SF3B1. That group does not do as well. The other thing that was surprise to a lot of us when we started looking at the data, deletion 5q with SF3B1 is not a good combination. So I think there could be some information gained more from the cytogenetics, but in general, the patient will be probably in the second category of the IPSSM. The blast 4% is a little bit higher, but so that's what I would look at the cytogenetics and the other mutations. I think from a practical point, like obviously this patient hemoglobin is 9, so maybe not yet transfusion dependent, but also we would like to know like their endogenous serum EPO level, because I think that will be important.
Thank you, Rami. Any other comment, Aditi?
Yeah, no, thank you so much, Guillermo and Rami, for those insightful comments. I completely agree that I think cytogenetics would add value here for us to really prognosticate the patient well. The serum EPO levels would also be helpful in understanding what therapies can be made available to this patient. One of the things that I would also like to know, though I know is low risk, is really the performance status of the patient, because as we know, 30% of patients with low risk MDS will eventually progress to high risk. So right at the beginning, I like to assess if these patients may be transplant evaluable in the future or not. But I think those would basically be the things we would be interested in.
I think that's a very important point, and I saw a couple of recent consults like this because I call this a young patient, right, 69. And I see sometimes they are not typed early, and I've been in situations where you have to start that a few months later. Sometimes these patients may progress in an unexpected fashion. So I totally agree with you, Aditi, that an early transplant consultation for a young patient like this, particularly even younger than someone in the 60s, is really something that I do in my practice. So you confirm the diagnosis. Now the next question, and this has changed a lot through the COVID times that still living here a little bit in Houston, is should you really start, when do you transfuse these patients basically? You think this patient that is a little bit symptomatic with a hemoglobin of 9, is he a candidate for transfusions or not? What is your threshold, Aditi?
Yeah, that's a great question. So actually, where I practice, we would not be initiating this patient actually on transfusions. Our threshold is typically about 7 grams per deciliter. But this is something which I think this is an interesting gray zone, because last year we also had data from like the large Sintra Rev study, right, which showed that you can actually prolong the time to transfusion with Revlimid treatment. So I would say, however, this is not something that has directly translated into my practice. And plus, this is probably not the right patient, but I wanted to bring up this example as well.
And that's actually a very important point of this kind of early intervention or early initiation of therapy that could be very meaningful. It seems that the patient eventually became transfusion dependent, and actually it was getting like 3 units over a 2-month period. So what will be the next step, Rami? ESA, does luspatercept have a role here? I mean, for the medalist trial, that was the original indication, this patient, if he had failed an ESA or was not a candidate for an ESA, this will be on label. But what do we do today?
Absolutely, yeah. So I think obviously the patient seems that he's transfusion dependent. We still don't know their serum EPO level, but we'll talk about this a little bit. But with simple model of the transfusion burden and the EPO level, you can actually predict the response to ESA. So if somebody is getting more than 2 units per month, that still starts dropping down in terms of response to ESA. And if the EPO level is high, I think based on what you will show us and hoping for approval in that indication, luspatercept will have a role as an upfront therapy. I would say, in my practice, I usually start ESAs before patients are transfusion dependent. Once they are in that symptomatic zone of anemia. We do try to keep patients above 8 because I think those guidelines of 7 are really for hospitalized patients. If you have somebody in their 70s with hemoglobin of 8, they are not functional on daily basis. So I usually would have started ESA before the patients are transfusion dependent. At this setting, if the EPO is high or the patient getting a lot of blood, I think based on what you will show us, you probably could make a case to move to the luspatercept from the get-going.
I actually agree with what Rami said, that I tend to try to keep those transfusion thresholds a little bit higher. If, COVID was difficult, but now we're kind of going back to usual. So 7 is too low for a lot of these patients. And then I see a lot of this early initiation of ESAs that I think is also a great idea. Indeed, actually, the original Nordic data showed that the only benefit with ESAs, I mean, in those days was combined with a GCSF, was actually in the very low burden patients. Okay, so this is where we are right now. This is an algorithm that we have used in the past. So, we're gonna focus right now for the lower risk side. We already defined them by IPSS, IPSSR, etc. And then, some of the interventions that we have: iron chelation, growth factors, luspatercept, hypomethylating agents. We already defined the del5Q entity. It's highly sensitive to lenalidomide. Just to mention the hypoplastic MDS, that is where I use actually ATGs, cyclosporin, L-Trombopac. And then, Dr. Aditi was talking about allotransplant. This is actually something that is not very commonly done in low-risk disease. But again, younger patients like this individual may be at some point candidates for that. So that's kind of what we have today. So what are the initial approaches that we have for anemia in our patients? So we have the ESAs that Rami already mentioned. This has been our standard of care for maybe 30 years. I'm not sure. Actually, I need to go historically to see first. But for as long as I've been a hematologist in training, actually, those are the drugs. They've been wonderful to our patients, but we could argue they are not super effective. They're different. You may need to use different kind of schedules, dose escalation, and most of these patients actually eventually will lose their effect. And then these transfusions actually are not trivial. I don't know that the community of people that follow this, that don't treat these patients, realize how actually difficult this is. So these are actually time consuming, they are toxic, they can give you both chronic and very severe acute toxicities, and eventually they become like a major burden to our patients. Indeed, actually, my perception is that this is probably what the patients care most. I skip a transfusion this week. Actually, I've been 2 weeks without a transfusion. This is sometimes how modest. You can be telling them about your BAF went down or whatever. No, they really care about this. It's a major issue for our patients. And this was particularly difficult also during the COVID pandemic, where this, as Aditi said, became really difficult. We also know that those patients that are transfusion dependent, and to be honest, when I saw this kind of data, I didn't really understand it, because to me it's kind of a circular concept. Yes, you are transfusion dependent, you have poor prognosis, but the reality is that this is really important to understand. So that very simple fact that you are in bone marrow failure with anemia basically indicates that the outcome of the patient is going to be significantly worse. So this is really important for our patients. So there's been quite a bit of an effort in trying to develop new compounds. A lot of this work actually came out of Albert Einstein with Amit Verma, a colleague of Aditi. But basically, through actually kind of studies that were not initially intended to improve anemia in patients with myelodysplasia or maybe thalassemia, the development of an antibody that basically modulated this TGF-beta pathway resulted actually in improvement in erythrocytosis in animal systems, and then subsequently in a number of phase 1 and phase 2 studies. There were actually 2 compounds, one developed originally by Dr. Komrokki, sotatercept, in parallel luspatercept. So we had actually ample evidence both in preclinical, clinical, and early clinical trials that this class of drugs are actually active in this context, improving erythrocytosis. And they do so in a different way than your prototypical ESA, by actually acting a little bit later in the erythroid differentiation, more as a maturating agent. That's why you may hear about them as erythroid maturating agents as opposed to an ESA. The drug to me is very interesting because it's kind of a dominant negative. So basically, it's an antibody that traps or binds to ligands that they go on and activate this TGF-beta pathway. And by doing so, basically, by inhibiting the inhibitor, they then promote erythrocytosis. There is some data that this may be related to SMAD2 and 3 signaling. I think we still actually have a long ways to really understand how these drugs work, although we have an idea of the importance of the TGF-beta pathway in erythropoiesis. As I mentioned earlier, we had the study called Medalist. In that study, we saw that this drug was well tolerated, was active as a second-line agent against placebo. This was actually New England Journal paper, plenary attached. And we thought, the community, including Dr. Komrocki, Dr. Sastry, that we should move this compound to the front line. And that resulted in the design of the study known as the COMMANDS trial. This was presented last Friday at the ASCO meeting, one of the, I think, most important presentations at this ASCO for sure in hematology. So this is a very large international trial that randomized, as you can see in the eligibility criteria, patients with lower risk MDS, and this is important to emphasize regardless of their ring sideroblastic status. So this was for both positive and negative RS patients with low risk disease by IPSSR. So this will include some patients with intermediate risk disease with less than 5% blast. These patients had to be transfusion dependent, as you see defined there, 2 to 6 units in an 8-week period. And then this is very important to emphasize because I saw at the ASCO meeting some questions or confusion about this. The patients had to have an EPO level of less than 500, but the reason for that has nothing to do with the luspatercept, actually. It has to do with the fact that the control arm here is epoetin alpha. And we know that these drugs don't really act very well over EPO levels over 500. So in a way to give a chance actually to the control arm to really work, we basically limited EPO level there. And then these patients were ESA naive. Basically, this is like frontline therapy for anemia. The study was stratified by EPO level, by the transfusion burden, and the ring sideroblast status. If you met that criteria, then you were randomized 1-to-1 to luspatercept using the same kind of label, 1 milligram per kilo every 3 weeks with a dose escalation. You are familiar with that from the Medalist trial versus epoetin alpha. There were also some questions at the ASCO meeting in terms of the dosing. Here we use the dose schedule that is kind of sanctioned by the FDA. So actually majority of these patients, I think, went to like the highest dose possible of the epoetin alpha. The same actually with the luspatercept. And then what is really important for this was the primary endpoint. And the primary endpoint was a composite endpoint that included transfusion dependency for at least 12 weeks with a concomitant increase in hemoglobin level of 1.5 grams per deciliter. So you have to have both to be called a responder. And when you look at this as the primary endpoint of this study, basically it was double for those patients in the luspatercept arm, 58.5% versus 31% for those in the ESA. This is the intent to treat analysis. This was how the study was designed, and it clearly shows that you basically double the response rate when you use luspatercept upfront as opposed to epoetin alpha in patients with low-risk myelodysplastic syndrome. We provided some kind of granularity to these results at the meeting. So the darker color is the luspatercept, the clearer color is the ESA, and basically you see that for those patients, regardless of the EPO level, this is in favor of the luspatercept. If you look at the transfusion burden, it's in favor of the luspatercept. If you look at those patients with SF3B1 mutation, this is in favor. We kind of expected that from the Medalist trial. Wild type refers to those that are SF3B1 negative, but we don't know actually. Well, we know because this is going to be updated at EHA next week, but there's going to be more analysis in terms of those that are SF3B1 negative that are referred here as wild type. Now, the question is in terms of this ring sideroblast phenotype. So it turns out that around 70% of the patients on the COMMANDS trial were RS positive. This was not planned. We don't know. Of course, this is not the typical distribution, although probably maybe Rami can tell us later, where around half of the patients would be RS positive. And I believe actually the IMERT study that we're going to hear soon also was enriched for this particular population. That's actually interesting. So what we saw is in the RS positive, of course, luspatercept is very superior, but here actually the response rate in the RS negative, that was around a third of the patients on this trial, was 41% for luspatercept versus 46% for the ESA. Now, what I think is actually as important, and actually if you ask me, if I was ever one day a patient with this disease, more important is actually the duration of the response, so the quality of the response. So this is the duration of transfusion dependency as an intent to treat. So you see on top the luspatercept, the bottom the epoetin, and when you look at this, actually it's 126 weeks for luspatercept versus around 77 for the epoetin alpha. Hazard ratio is around 0.45, so basically you're kind of doubling the amount of time that you're free of transfusion. And that actually, if you do the math, that is quite simple, constitutes almost an extra year free of transfusion. This is really not trivial. I think this is really powerful data. And then, when we look at, for instance, this issue of the responses for the RS positive versus RS negative, actually, when we look at the duration of responses for both morphological entities, what you see actually, as expected in the RS, so it's 120 weeks versus 47, highly significant. But actually, even if the numbers are small, and maybe the study is not fully powered to really answer this question, the curve is actually in favor of the luspatercept, where you have more durability of these responses. So I think this is really important data suggesting that you have an increased rate of response and that the quality of these responses is likely superior with luspatercept as opposed to an ESA. The other important piece is the safety. They're very similar, and if you look at grade 3, 4 toxicities, a lot of these are actually disease-related, like the cytopenias, etc. It was maybe a little bit more patients with TE, but there is a point that I learned actually during the meeting, is that this actually account for events through the time the patients were on trial. And actually, these patients on the luspatercept were actually probably twice as long on a study compared to the ESA. So actually, if you divide that by half, there's no difference in terms of any of these toxicities. So this is actually a very important point, that exposure was significantly longer. If you look at progression to high-risk AML, progression to AML, or death, they're basically similar. I think it's going to be very important for this study to keep reading over the years and see actually if this kind of early transfusion dependency, longer duration of transfusion dependency at some point really changes the natural history of this disease. So basically, we thought in the presentation that this actually shows clearly this superior to an ESA. This is significantly longer duration of these responses. And this actually in this head-to-head study probably suggests that this drug should be, if it's approved at some point by the FDA, if they think that's appropriate, should be probably the standard of care for a majority of our patients that are becoming transfusion dependent with low-risk myelodysplastic syndrome as their first-line therapy, regardless of mutational status or morphology. There are some practical issues with this drug that sometimes we see in the community, people not really remembering. You increase at a dose of 1 milligram per kilo. Dr. Konropki remembers this very well. This is kind of an early FDA safety issue with some of the studies because they didn't want us to go to hemoglobins of 15, 16. We thought this was funny, but of course, there's a safety issue there. If you don't control for that and patient has a vascular event, that will be very tragic. But eventually, you will probably have to escalate the dose up to 1.75 milligrams per kilo. You probably have to do some mitigation strategies for patients at high risk of thromboembolic events, hypertension. But I have to tell you that we've treated over 100 patients in our practice, and this is actually really a very rare situation that is really very seldom problematic in our practice. And I would like now basically to introduce my dear friend and colleague and a leader in the field, Dr. Rami Konropki from Moffitt Cancer Center. Rami?
Thank you, Guillermo. Thank you for the kind introduction and setting the pace very nicely for me and Aditi for the next part. So this is continuation. The same patient I think we talked about eventually got started on erythroid stimulating agents, and it seems drove around 15 months, which probably is around where we expect those things to run out. And you just showed us the data, even sometimes less than that. So the patient after 15 months is becoming back transfusion dependent, again back to 3 units every month. And this time, obviously, the EPO level is high. So I think the questions that I will pose for both of you, maybe we'll start with Aditi, like in your mind, is this a ESA failure? And if so, what would be our next line of therapy?
Yeah, this is actually a pretty common scenario that we do see sometimes referral from the community or patients that we're treating in the clinic. So thank you, Rami, for the question. But, when you start seeing this sort of pattern of where they lose response to ESA, one situation could be that are they failing or becoming refractory to ESA therapy? And should we start considering at this point second-line luspatercept? But one thing I also worry in this situation is the patient progressing? Should we be worried that the percentage of the bone marrow blasts may go up? So for me, this would really be an indication to remarrow the patient and get a stance on what is going on in the bone marrow. Do we have additional mutations to deal with? Have there been any changes in the cytogenetics? Before we initiate any other new type of therapy? I would like to hear what Guillermo also has to say in this regard.
I agree totally with Aditi. One thing that I always teach my fellows is that this disease is very dynamic. It changes. And I think every time that you're going to make a therapeutic change, as you're going to do here 15 months later, I think it's totally indicated to do that, because you may find occasionally new molecular changes, new cytogenetics changes. Sometimes these patients, you think they're still in low risk, they progress to high risk. So that's a very important and wise point from Aditi, that you need to make sure that you're still treating the same entity. I totally agree.
Absolutely. Thank you. And would both of you be thinking of luspatercept if we confirmed no disease progression?
I think so. I mean, this is right now the label, right, of Medalist. This patient has SF3B1 mutated ring sideroblastic anemia, has received ESA, and is now transfusion dependent. So this will be kind of the standard of care.
Absolutely, absolutely.
I totally agree. I would do the same. Yeah.
Yes. And then obviously we will be talking about emtilistat. I'll show you some of the data that we presented also on Friday. But would be that a consideration? Could newer modalities be used in the second line, or they are going to replace luspatercept?
Yeah, I mean, I think if we follow what's happening, you know, the COMMANDS data is very positive. That probably could move luspatercept to front line. Then you will not be using luspatercept as a second line agent. I will not really, unless, as you published recently, you come with some type of combination or something like this. Traditionally, actually, in the past, before we had luspatercept, we will treat these patients with a low dose hypomethylating agent type of approach. For sure, the three of us will try to enroll this patient in a clinical trial, and we got luspatercept a couple of years ago. You will do that, but you know, you could probably do better than the results that we had with Medalist.
Absolutely. Sorry, go ahead, Aditi.
No. Just wanted to add, I completely agree. And then, sometimes, when we, I think with the imetelstat, what's really interesting is the fact that it's targeting something which is more mutation agnostic, right? Just like telomere biology. So these sort of drugs are also very interesting for us. And you'll tell us more about it, that this may have more broader application too, in the sense of if you're missing some data points, you can still apply these treatments. Yeah.
Absolutely. And I agree with Guillermo. I think what will happen, or I hope what will happen, is we'll move the landscape, that luspatercept eventually will become more a first line, emtilistat will be second. I think for patients like with MDS ring sideroblast, SF3B1 mutation, they have a very good chance of response to luspa in general, which still have probably more favorable profile, safety profile. So I always probably will go for that as a first line. So all right, so I think we've been talking about this, but I think, this is an important issue in the community, because I see a lot of patients that are almost ongoing on ESA, where really I question the benefit. There had been several trials or studies trying to look at ESA responses, defining ESA failure. I think in general, roughly around 40-50% of the patients respond to ESA from the get-going. Dr. Sophie Park from the French group published a large series combining Europe and USA data, showing that even when we look at not solid criteria like trial, around 50% of the patients respond. Eventually, obviously, everybody has ESA failure. It could be a primary failure that somebody would not respond from the get-going, which typically is around half of the patients, or eventually everybody will have a secondary failure. And when you look at the outcomes for those patients, their survival is measured in like less than 5 years. So it's not, as we think that those patients will be okay, particularly if they are transfusion dependent, those numbers drop down even more significantly. And the primary ESA failure is associated with higher risk of going to leukemia as well. This is the famous Dr. Helmstrom model that we really can predict the response to EPO simply, looking at the magnitude of transfusion burden and the serum EPO. Like, I never memorized the model completely, but in my mind, if somebody takes more than 2 units of blood or their EPO is above 500, their chance of response to EPO is less than 10%. So, and even a combination of those things. And what was striking to me when Guillermo was presenting the commands, when you look at that subset of patients, 200 to 500 EPO level, their response to erythropoietin was 10 or 12%, I think, so very low rate, emphasizing this in a randomized clinical trial. Now, this is my approach, and I think I'm excited that hopefully I'll have to update those slides and start kind of entering the data from the commands and the emtilistat on those. But obviously, when we treat in lower risk, in most of the patients, we are treating for anemia. That's the major indication. Rarely, if ever, we'll treat for isolated neutropenia or thrombocytopenia. But sometimes the neutropenia and the thrombocytopenia can dictate your choice. If somebody have anemia, but their platelets are 40, you're not necessarily treating the thrombocytopenia, but it may not allow you to use lenalidomide, for example, even if we are using it in non-del5Q. So I think, in general, after ESA failure, if patients have deletion 5q, lenalidomide is the standard of care. And I think Aditi referred to the elegant Spanish Central Rev study that's actually even moving the lenalidomide earlier a little bit in patients with del5q with symptomatic anemia. To Guillermo's point, like this transfusion dependency was always like no brainer for me. Yeah, like if you are transfusion dependent, you are gonna do worse. So what's the point? But then you look actually from that study that the magnitude or the survival correlated with the number of units. So with every 2 units, you see the survival curves dropping. And similar to Guillermo, I always thought this is disease biology, that if somebody is having more transfusions, they have more bone marrow failure. But we're starting to look at data of what happens if patients respond to a first or second line of therapy, if they become transfusion independent. Dr. Santini presented a little bit from the medalist study and the MTELSTAT studies, I think, and at least a medalist I know for sure, that responders that became transfusion independent actually had better overall survival. So maybe there is a point of, transfusion dependency more than just the, transfusion itself. The other thing, there is a lot of data coming on anemia per se and the interaction with, congestive heart failure, cardiac remodeling. So I think what Aditi was saying also, to start thinking of transfusion-free survival or time to transfusion dependency is very important. So in general, I start patients if their hemoglobin is less than 9, I would start thinking of ESA. I don't wait till they're transfusion dependent, as I mentioned. And, if there is ESA failure, as we mentioned, del5q, len, non-del5q, if they have MDS with ring sideroblast, luspatercept, I think, as Dr. Garcia-Manero referred to, the medalist, had been set as the standard of care there. For the non-del5q, if they are young or hypoplastic, we do have similar approach to Dr. Garcia-Manero using immunosuppressive therapy. The other patients, sometimes if they are just anemic, we use lenalidomide plus erythropoietin. And finally, I think we've been working on this abbreviated course of hypomethylating agents, or nowadays maybe oral hypomethylating agents. So this is what Dr. Garcia-Manero was alluding to, the medalist data. The medalist was done, in patients that were lower risk MDS with ring sideroblast, transfusion dependent, ESA failure. So that was the group, and that's where the label or the approval is. And you can see here, the primary endpoint was 8 weeks. But if you even look at the durable responses, extending 12 weeks or 16 weeks, you can see that the luspatercept was way superior. Roughly, we say around 1/3 of the patients will respond, becoming transfusion independent. Actually, the magnitude of benefit is more, as also Guillermo alluded to, if you start those patients before they are heavily transfusion dependent. If you look at the low transfusion burden patients, the responses can approach 60 or 70%. Among the patients that are highly transfusion dependent, sometimes you will not be able to achieve transfusion independency rather than reduction in the transfusion burden. There was also update on data from Dr. Finot at the past ASH, looking at the durability of the responses and the cumulative duration of transfusion independency, which actually approaches almost like 80 weeks. So it's almost approaching 2 years in those patients after ESA failure in the medalist study. So definitely very active treatment in patients with MDS ring sideroblast after ESA failure. Now, what we presented this Friday are the phase 3 randomized clinical trial with MTELSTAT. So MTELSTAT is first-in-class telomerase inhibitor. We've actually been testing for years in both MPN and MDS. It turns out that telomerase activity is increased, obviously, in many cancer cells, including MDS cells. And the telomere is shorter. So sometimes by using a telomerase inhibitor, we are shortening it further, almost the principle of synthetic lethality for the clone. And Dr. Zidan presented this data on Friday as well. So there was an earlier study, the phase 2 emerged, that Dr. David Stinsma published in JCO, showing in phase 2, we saw around 40% responses, durable responses. Around 1/3 of the patients remained more than 1 year transfusion independent. So based on that, the MTELSTAT or the eMERGE phase 3 trial was conducted. Again, those were lower risk MDS patients. They had to be transfusion dependent. with relatively a heavy burden. So all of them had to have more than 4 units of blood every 8 weeks. Obviously, no prior treatment with LEN or HMA. And those patients had to be either ESA relapse refractory or have low chance of response. And the randomization was 2-to-1. 118 patients got emtanstat, 60 patients placebo. The emtanstat dosing is 7.5 milligram per kilogram as IV infusion once a month. And this dosing is a little bit different from the studies with myelofibrosis. When you look at the baseline characteristics, as Dr. Garcia-Manero also mentioned, it was also enriched with patients with ring sideroblasts, around 60%. I think part of this we are seeing with the COMMAND and eMERGE that basically there was some selection bias by the physicians, the investigators, because there were, like, obviously everybody knows the luspatercept works in MDS ring sideroblast. Everybody also knew that emtanstat had a stronger signal in that population. But part of it is also because the patients with MDS ring sideroblast do well in general in terms of the least chance of progression to high risk MDS or AML. So they become prevalent in practice. Those are the patients that have lines of treatment failure and they go on clinical trial. Nonetheless, in this study, as I mentioned, 60% of the patients were, ring sideroblasts, and actually almost half of those patients were heavily transfusion dependent, requiring more than 6 units every, 8 weeks. So obviously the study met the primary endpoint. The 8-week transfusion independency was almost 40%, but even when you look at 24 weeks, almost 1/3 of the patients were transfusion independent. I think what was important and interesting is that the responses both in ring sideroblast positive and ring sideroblast negative were almost similar. And the responses were, regardless of the transfusion burden. So even patients that had more than 6 units transfusion burden at baseline had a similar response, where actually many of the other treatments don't do as well. So that's appealing. The other thing that was shown that the median hemoglobin increase on study was 3.6 grams. I think this is the second after lenalidomide in del(5q), where we see a drug that can have that robust increase in the hemoglobin. And again, those responses are durable. So when you look at the median duration of response, those patients were transfusion independent for almost a year, compared only to 13 weeks with the placebo. Also was shown, and I think Aditi alluded to this, that this treatment could have potential disease modification. There were data presented on several mutations, including the SF3B1, ASXL1, that you see reduction in the allele burden. And there is actually some correlation between the reduction in the allele burden and the hematological improvement seen. So this is something obviously we're going to be exploring further, but sounds promising that there could be potential disease modification. How about the safety? In general, relatively safe. The major adverse event with this is myelosuppression. There are grade 3 and 4 thrombocytopenia, neutropenia, almost in half of the patients. They typically happen in the 2nd and 3rd week for a duration of almost a week, then the counts recover. So with, holding and those adjustments, there were not increased, febrile neutropenia events or mortality upfront, but definitely a grade 3 and 4 neutropenia and thrombocytopenia are things to observe in the middle of the cycle, and it may need to be mitigated by delaying the next cycle by a week or by dose reduction for the subsequent cycles. What about other things in development? Obviously, hypomethylating agents are widely used in the United States for lower risk MDS. In Europe and Canada, they are not approved. So I always say this is USA phenomena. Hypomethylating agents were approved in the higher risk MDS. I think Guillermo had worked extensively on trying to get the benefit for lower risk MDS patients. For a while, I think people used to jump on those treatments as a first line, and we are realizing that that's not probably the best way. Guillermo and I actually published years ago showing that the survival for those patients after HMA failure was only 18 months, even in the lower risk. So we see this bone marrow failure syndrome. So we preserve those as later line of therapy, or sometimes when the thrombocytopenia and neutropenia will dictate your choice. Like you cannot use, as I mentioned, lenalidomide in somebody with platelets of 30. Probably even emtanstat is not going to be a treatment of choice in patients with cytopenias. So I think what's been pioneered first is shorter duration of hypomethylating agents. Again, Guillermo had led the MDS consortium study that we are waiting to see the results of a randomization of 5 days AZA versus 3 days decitabine or azacitidine. But in the phase 2 data, we see really actually very comparable, and I think it's reasonable sometimes, particularly in older patients, to use those 3 days regimen. Also, he's pioneered over time the use of the oral decitabine combined with cedazuridine. This is now approved, and the label does include intermediate risk by revised IPSS. And basically, cedazuridine is a inhibitor of CDA enzyme, so this allows the absorption of decitabine. So this is almost 99% bioequivalent to IV decitabine. And it's also been looked at a lower risk MDS. This is again data from Dr. Garcia-Manero looking at lower dosing of the oral decitabine cedazuridine in lower risk MDS patients, showing early promising responses. In addition to this, obviously, we have oral azacitidine in development. As you know, oral azacitidine is approved for maintenance in AML, but the dosing is not the same. And oral azacitidine is not equivalent to IV or subcutaneous azacitidine. They cannot be used interchangeably. Again, Dr. Garcia-Manero presented data in lower risk. They selected patients that were higher risk, lower risk in a way, that they have thrombocytopenia, higher risk features, and they were treated with oral azacitidine, but I think the dosing was even more than the maintenance. So they realized early, although the drug had activity, they were seeing hematological improvements, platelet response, but there was excess febrile neutropenia. So he's coming back now with shorter duration, less dosing, trying still to figure out. So the bottom line, I think we have oral decitabine being further explored in lower risk. We have oral azacitidine. We have a different format of oral azacitidine similar to the oral decitabine, all in clinical trials in lower risk MDS. And I think with that, I'll stop and I'll transition to Aditi to take us through the higher risk.
Thank you so much, Dr. Kamrokji, for such a wonderful presentation. And this is a perfect segue now to move into just quickly some updates in high-risk MDS. So now actually we're going to go back to David. And if you now see additional testing have shown that he has a TP53 mutation and complex karyotype, and assuming that now his functional status is declining and a donor is not currently available, I would like to pose the question to Dr. Garcia-Manero is, what options would you pursue at this point for a patient with high-risk MDS when stem cell transplant looks challenging in this situation? Would you go back to HMA therapy, combinations? What are your thoughts?
Yeah, so this is a very difficult situation. We see this all the time now for one reason or another. And this constellation of the P53 mutation with the complex karyotype is very difficult. So we do not tend to give induction chemotherapy to these patients because we think you gain a lot of toxicity and it's not clear that the responses are greater than with a hypomethylating agent. If you don't have a trial in the community, the standard of care will be single agent azacitidine, decitabine, oral decitabine. Actually, we don't know if any of these other combinations will be better actually than single agent HMA today. So I think that will be acceptable. Some of these patients actually will respond to therapy. And then the question that you were asking is, if this patient had some type of cytogenetic or even sometimes occasionally molecular response, would you consider this patient for a transplant followed with some type of maintenance therapy post-transplant? So that's what I will do. Of course, I will consider a clinical trial. The vignette talks about anti-CD47 antibodies, for instance, magrolimab, that had been proposed to be agnostic of the mutations. I think BCL2 probably doesn't have a big role in this particular molecular context, but this is a difficult disease with a prognosis that is actually well understood, maybe a survival of around 1 year or so. So very difficult and becoming common.
What is your experience, Rami, with this patient population?
Yeah, I'm totally in agreement with Guillermo. I think this is tough population. Obviously, we always say clinical trial, but not, most, may not have access to a clinical trial. Obviously, I think all P53s, if there is access to clinical trial, they should be treated on trial. But outside of trial, I totally agree with Guillermo. Like, we shy away from intensive chemotherapy, and I don't actually even add venetoclax. We've been doing it sometimes out of the box in MDS, some selected patients, but not the P53, particularly if they're not going to transplant. So I think hypomethylating agents, you could argue, like, even I think Guillermo presented some data on the P53 that they actually do pretty well with the oral decitabine. It was a mixed group. They had a little bit more intermediate, but still, if not better, not inferior. So I think it will be a convenient option to think of oral decitabine for this patient. I think, Aditi, your group is trying to pioneer this kind of metronomic dosing, lower dose, kind of continuous. So obviously those could be a little bit out of the box approaches, but looks promising. But the gist is the backbone is just a hypermethylating agent.
No, absolutely. And I so agree with both of you. This is the hardest patient population to treat. So just diving in, we're just very quickly going to look at our algorithm for how we treat patients with high risk MDS. And as we discussed at the beginning of the talk, right off the bat, we really want to assess whether these patients are candidate for transplant, because the way that we think about it is that, is this sort of therapy or bridging therapy that we can use to actually get this patient to transplant, because even in this day and age, allogeneic transplant is still the curative treatment for patients with high risk MDS. So this is kind of here exactly where the different types of drugs that we talked about, HMAs, oral HMAs, and high intensity chemotherapies have fallen out of favor even for us, but clinical trials are also highly favored. So let's talk about what are the possible available emerging modalities which have interesting mechanisms of action that we could use to treat patients with high risk MDS. This is from a review that we had recently published, which highlights some of these interesting targets. But the ones that we're specifically going to talk about today are really the CD47. We want to talk about TIM3 as well, which is highly expressed on the surface of T cells and leukemic stem cells. And then, of course, venetoclax. So the CD47 blocking antibodies are those that have really gained traction in acute myeloid leukemia as well as high-risk MDS. And one of these drugs, magrolimab, is actually blocks this very important immune checkpoint, CD47, which is expressed and basically expresses this sort of like do not, and then this do not eat me signal, which is expressed, allows these tumor cells to escape sort of detection by the immune system. But magrolimab, by blocking the CD47 antibody, induces a macrophage-mediated phagocytosis of the tumor cells. And the combinatorial strategies here appear to be successful, and it does synergize with azacitidine while upregulating these eat me signals, which can then be targeted. So the data from the phase 1 study of magrolimab and AZA is here. And as we can see, there is actually a very good CR and molecular CR rate of 60% and above with patients with MDS as well as AML. And what is actually very interesting and good is that even in patients that are TP53 mutated, or these patients that Dr. Garcia-Manero alluded to, the TP53 biallelic losses that we're really seeing pretty good rates of CR and molecular CR. So I think that future studies will give us some more information, and across different mutational types or mutational spectrum, we are seeing activity of this drug. And safety-wise, so as we know, we have this on-target hemolytic anemia for which we give the priming dose in the first cycle. But once this is actually, you get past this with the good monitoring and transfusion support as needed, the drug is otherwise well tolerated in combination with azacitidine, and there's a low rate of discontinuation really due to adverse effects. And even though it's an immune targeting drug, there aren't any significant immune related side effects that we see as we see with some other checkpoint inhibitors and stuff. So we have the phase 3 ENHANCE study, which is actually ongoing, and it will give us additional data on magrolimab and azacitidine combination. And here the trial is the randomization is 1:1, where you have magrolimab plus AZA versus the placebo and azacitidine. And the patients that are being enrolled on this study are those with untreated MDS that are high risk. Other combinations or immune agents that are also very interesting are sabatolimab, which is the TIM3 antibody. As we said, TIM3 is selectively more expressed on leukemic stem cells in AML and high-risk MDS compared to normal stem cells. There are also other CD47 blocking drugs that are currently in trials, and they appear to look quite promising. So we're awaiting further data actually from these studies. Venetoclax, as we know, venetoclax and AZA has been a very successful combination in AML, as demonstrated by the VIALE-A study, which helped venetoclax get the approval in AML. And the mechanism of action really of venetoclax is that it blocks the BCL2 pocket where it binds the apoptosis effectors, BIM and BAX. And there's a massive activation of these apoptotic effectors and pushing cells into apoptosis. And when you look at data, even in high-risk MDS, this combination of AZA and venetoclax is truly synergistic. So I don't use this word lightly because, we do talk many a times of combinations and combinatorial strategies, but seeing true synergy is rare. And this is what we have seen in AML. And we hope we can actually exploit this for our high-risk MDS patients as well. So this is some data actually from the phase 1 study of venetoclax in combination with AZA. And, you can see that there is a pretty good CR and a molecular CR rate. And that there are some, like as we mentioned, the TP53 patients don't respond perhaps as well to venetoclax, but we do see some responses here, but we need more studies to tease this out further. And then if you look across the board, at patients that might have ASXL1 mutation, some of these more high-risk MDS patients, they seem to have a pretty good overall response rate, CR rates that I think need to be further teased out. And the advantage I see of this therapy is that it's a powerful therapy that you can actually use to bridge the patients to an allogeneic stem cell transplant. Now, one of the things to be careful about is really the duration of venetoclax in MDS, which as in these trials we can see are different compared to the AML studies. We have restricted it to 14 days and the appropriate dose reductions need to be followed for myelosuppression. So we have the ongoing phase 3 Verona study that is assessing this combination further. And just, I'm going to skim this slide just in the interest of time, but IRAK4 is another very interesting target that has been identified in high-risk MDS with ongoing early phase studies. So this is a strategy that we're actually developing at Albert Einstein that Dr. Kamrakji alluded to, where I saw a question in the chat that what do we do with very frail patients, that even those that are not able to get like even HMAs or any standard of care treatment, we're actually piloting this low dose kind of metronomic regimen where we're treating patients just weekly with decitabine and venetoclax. And while this is an ongoing study and I cannot, give a lot of data points about it, what we're actually seeing is that patients are remaining transfusion independent. There is actual hematologic recovery. We're seeing VAF reduction. But since this is a prospective study, only time will tell, whether it affects, progression-free survival, overall survival. But needless to say, this is a very well-tolerated regimen, and we are not seeing any discontinuations due to treatment-related adverse events. And just some retrospective data that we're presenting on EHA on patients that we treated with TP53 mutated AML and MDS, we did see that, a small percentage of these patients that were treated did achieve a CR. So we're kind of looking forward to how this trial is evolving. And I'm going to stop right there. And I think, thank you so much, everybody, for your attention. And this has been so interesting. I also learned a lot of new things. Let's move on to the Q&A.
Yes, so thank you. That was phenomenal, Dr. Sastry. So we have a few minutes for questions, but I'm going to ask you both, Rami and Aditi. So let's ask a very important question let's start with Rami. So we've been basically accustomed to wait, let's say, 8 to 12 weeks to assess ESA response in first line with luspatercept. The question is, in view of that luspatercept in second line works better in low transfusion burden, what do you think is the sweet spot to say, okay, ESA is not really working, I want to transition to second line luspatercept? How do you do that?
Yeah, I think, that's a very good question. One thing, I personally, most of the time go to a higher dose of the ESA. Like I would go for like what is equivalent of 60,000 erythropoietin, because historically we do like 40,000, we wait 8 weeks, then we escalate to 60,000, that's another 8 weeks, the patient is getting blood through. So I will go to like a 60,000 from the get-going equivalent. And I think you still probably want to give it the 6 to 8 weeks and then move. Now, once we move to luspatercept, and I think I was seeing question about that as well, the key is really this rapid titration, like, because many times I see the patient coming after 6 injections, they were never titrated above the 1. And you nicely alluded to that, like you have to go up. After 2 doses, 1.33, after 2 doses, 1.75. Actually, Dr. Platzbecker showed data in the higher transfusion burden. Almost everybody needs dose escalation. So sometimes if I have a patients that are highly transfusion dependent, I will give them, like, I will try to get them the 1.75 from the get going and not even do the dose escalation. But that's what I do. But I think the data is that probably to me saying that we should start having a lower threshold jumping off if ESA, if we are trying ESA, particularly with the efficacy that you showed us today from the commands.
I have to ask you 2 questions, and then I have 2 for Aditi, then I think we'll close. But you have done work on this, I want to ask you. So what is the experience actually combining an ESA with luspatercept? You recently published on this, Rami.
Right, so obviously what we publish are case series. As you explained, luspatercept works on terminal erythroid differentiation. ESAs worked earlier, so technically or hypothetically they could work together. What we put together was a small case series of almost 30 patients. We took ESA failure, luspa failure, and then did the combination. There were only a few patients that got it from the get going. But even after the failure of the 2 therapies, we saw almost 1/3 of the patients responded to the combination. The most important predictors were some response to luspa. So if it was a secondary luspa failure, somebody had just some transfusion reduction with luspa, but not a very good response, you add ESA, you get it. The primary luspa failure had less response. Endogenous serum EPO level. So if those patients had EPO above 500, they were less likely to respond. So I think we'll see a lot of trials. I think in Europe, there is now upfront luspa ESA ongoing. We have like an investigator-initiated study for luspa failure to come back and add ESA again to see for salvage.
That's very good. Very quickly, how fast are the responses with imetelstat? And then we move to IDT.
Yeah, I think the average was around 3 to 4 months, but were there some group patients that were like way later responders. This is similar to a little bit like hypomethylating agents or lenalidomide, that in the first couple of cycles, you probably are just dealing with that mid-cycle myelosuppression. And it's really in the 3rd, 4th cycle you see responses.
Thank you. Aditi, so we're very excited about the IPSSM, all this stuff, very cool. But the question here is, what happens in places where they don't have this? Here they say rural clinics, but the reality is there are many countries, continents that actually don't have access to even cytogenetics. So how do we deal with this? I know this is kind of a theoretical question, but I think it's a very important one.
Yeah, so I think, you're absolutely right, Guillermo. And, thank you for the person that asked the question. I mean, this is a reality is that, a lot of places don't really have access to accurate cytogenetic and molecular data. And this is like a huge drawback that we must acknowledge as we keep updating our prognostic systems, that in large parts of the world, they are not usable, unfortunately. The one thing I will say, though, is what I have seen is that you do. So first of all, when you showed us the nice timeline, we do have lots of drugs available there. If you think about it, we have HMAs, we have lenalidomide. And, in most parts of the world, even in rural areas, I think eventually you can get cytogenetics. I do agree molecular data can be kind of challenging sometimes. But I think this is perhaps even an opportunity for us that as newer therapies become approved, right? Like those that we know are specifically good for patients with SF3B1 mutations, etc. How can we liaison and partner with the community, to be able to really create like a dialogue about this and provide our help and support to them, to be able to treat these patients effectively?
Very quickly, because I think we have like 10 seconds.
Can I add one thing quickly to this?
Yeah.
So I think that the one thing I think you and I talked about before is like important message that the Italians published in the JCO. Not every patient that's going to be upstaged by the IPSSM we should treat at higher risk, because like they looked at hypomethylating agents. So by the fact once somebody is upstaged, if they are younger thinking of transplant, yes, those models are very strong predicting survival. but there's not automatically that somebody gets upstaged by the IPSSM, we have to jump on HMA. I think if the patient problem is anemia, we could still go stepwise. The only robust data on this that they are good predictors of survival, but it's not automatic reflex to treat them all as higher risk.
That's a great point.
Then very quickly, Aditi, do you ever delay transplant in good responders? There's a question about the timing of transplantation. How do you do that?
Yeah, that's a good question. So actually, no, we don't really delay transplant in the good responders because we know that eventually these patients will relapse if they have high risk MDS. And, this is probably the best window for us to transplant them when they're responding and they have a low blast burden. And, we're really able to effectively take them to transplant. So absolutely, I think, the earlier we start the workup, the better, but we don't wait.
Agree. And then last question, very provocative to Dr. Komrocki. So do you see a role? Do you think that we need to do studies with imetelstat in first line, similar to the commands?
Yeah, like I think that would be interesting. The more we see data on the potential disease modification, maybe in the future, yes, like there could be a role if we identify a subset. At this point, as I mentioned earlier, like, you look at the efficacy and the adverse events, and luspa doesn't have the myelosuppression. So if all our goal is to achieve transfusion independency, I still see imetelstat coming as the second line of therapy. However, like the more we get this, you could even, like I've been thinking, even potentially we could combine those agents, because like technically you published that sometimes with luspa, and there are like other drugs now in development from the TGF beta that could have trilineage responses. So they could offset some of the myelosuppression you see. So, I can foresee something like that in the future, that we move really upfront with the, seeing if we can modify the disease early. At this stage, I probably will still sequence luspa first if the patient has a good chance to respond to it, then imetelstat.
Thank you. I have to say that every time we do this together, I learn a lot and I enjoy it very, very much. It's really a pleasure to do this with you, Aditi and Rami, and I hope this was of interest to the audience, and thank you very much for PeerView to putting this program together so nicely. Thank you very much.
This activity is certified by PVI, PeerView Institute for Medical Education. Remember to download the slides and practice aids.